The more that you read, the more things you will know. The more that you learn, the more skilled one becomes. Jain, and a very good morning to respected Principal Sir, Head of the Departments, faculty members, and dear students. Warm greetings from Swami Vivekanand Subharti University, Meerut. Our university has been established under the aegis of Mahayana Theravada Vajrayana Buddhist Religious and Charitable Trust, Meerut. The university has achieved a commendable record in the field of healthcare, education, and social welfare. Swami Vivekanand Subharti University has 19 colleges under one roof, and Subharti Dental College and Hospital being the pioneer of all. With this, Subharti Dental College and Hospital has begun a series of alumni lectures 2024. I, Dr. Roopsi, Assistant Professor in the Department of Periodontology and Implantology, would like to welcome the head of our department, Dr. Mayur Kaushik Sir, to kindly welcome our guest speaker for today.
Jain, everybody. It is an honor for us to have Dr. Aena as the guest speaker today with us. About Dr. Aena, Dr. Aena Jain Pundir has completed her BDS in 2007 from ITS Ghaziabad and her MDS in 2011 from Subharti Dental College and Hospital. She has academic experience of more than 12 years and she is currently working as the professor and head in the Department of Periodontology and Implantology, Rungta Dental College, Bhilai, Chhattisgarh. I'm sorry. She has more than 20 international and national publications and also patents to her credit, like self-cleansing toothbrush with ultraviolet disinfection, biocompatible and personalized 3D printed dental implants for enhanced osseointegration. She has given many presentations at national level. Dr. Eena Jain Pundir has been a part of many research studies on bone grafts and implants. She has a keen interest in laser dentistry as well. Along with being a very renowned academician, she has also been running her successful dental practice in Bhilai for more than 12 years. It is an honor to have Dr. Aena with us today.
Without any delay, I now would like to request Dr. Reena ma'am to start with the lecture.
Good morning, everyone. Myself, Dr. Aena Jain Pundir. As sir has already introduced me, I am working as head of the department, Rungta College of Dental Sciences and Research, Bhilai. Before starting my presentation, I would sincerely thank Dr. Mayur Kaushik sir for giving me this opportunity for today's presentation. Sir has always been a mentor and guide to me throughout my journey, and whatever little clinical work I know, it is all to sir's credit. I'm really grateful to you, sir. My sincere thanks to Nikhil, sir, Principal Subharti Dental College, for inviting me over as a guest speaker. Thank you so much, sir. So let's start with the presentation. A brief introduction before my presentation of myself. I am alumni of Subharti Dental College 2008 batch. I am working as a periodontal consultant, laser and implant specialist in Chhattisgarh with a teaching experience of more than 12 years. I have done various research studies on bone grafts, GTR, PRF, lasers and implants. I have more than 20 PubMed national and international journals, and I am successfully running my clinical practice for more than 12 years. I have also 2 patents to my credit, which sir has already mentioned. This is my department at Rungta Dental College, Bhilai, Chhattisgarh, where I am working as head of the department. And this is the clinic where I do my clinical practice. So let's start with the presentation. Just a brief introduction of what exactly is periodontium. As we all know, it comprises of two hard and two soft tissues. The hard tissues, mainly the alveolar bone and cementum, and the soft tissues being periodontal ligament and gingiva. So it is a connective, basically all these comprise a tissue that supports the tooth and protects the teeth against microflora and makes, just 1 minute, the slide is not being shown for Rupsi. Is it visible completely?
Yes, ma'am, it is visible.
I think the whole slide is not visible. Is it visible?
मैम, यस मैम, नीचे से थोड़ी सी कट रही है, हल्की सी।
So what should I do for that?
मैम, इसके लिए तो वी कांट डू एनीथिंग।
Okay, it will be like this only.
यस मैम।
Okay, no problem. Okay, we'll carry forward. Okay, no problem. So
ओके।
it is basically a connective tissue that supports the tooth and protects the teeth against microflora and makes the attachment of the tooth to the alveolar bone. Now, what exactly is periodontal disease? It is the result of infection and inflammation of gums and bone that surround and support the teeth. So, any infection of the gum, it leads to gingivitis because of inflammation, and then as it reaches the bone which surrounds the teeth, it leads to periodontal disease. Now, as we all know, females they experience a series of hormonal changes in their body which directly affect the gingiva. Few are the physiological changes, mainly including puberty, menstrual cycle, pregnancy, and menopause. And few are the non physiological changes, which mainly occur because of oral contraceptives. In this presentation, we'll be mainly focusing on the physiological change, that is pregnancy, and how does it affect periodontium and vice versa. So just before starting, how does pregnancy affect periodontium? We'll be talking about few systemic changes that occur during pregnancy. The normal pregnancy term from conception is 37 to 42 weeks, and it can be divided into three trimesters: the first, second, and third trimester. Now, delivery, if it occurs at less than 37 weeks of pregnancy, it is regarded as preterm. The average birth weight is taken to be about 3.5 kg, and if the birth weight of the baby is less than 2.5 kg, we take it as low birth weight. So these are the few terms which we will be talking in our presentation: preterm baby and low birth weight. So preterm is less than 37 weeks and low birth weight is less than 2.5 kg weight of the baby. Now, the numerous physical and the physiological changes that occur during pregnancy affect major body system, resulting in localized physical alterations in many parts of the body. So, in a pregnant female, there are physical and physiological changes overall in the body, and few specific periodontal changes are there which we will be discussing today. In the cardiovascular system, if we talk about, there is increased cardiac output, the heart rate is increased, the blood pressure is reduced, there is increased risk of hypertension. Many a times because there will add cases of hypertension also. And also, it is a very frequent finding of varicose veins which occur in pregnant female, and the leg edema also increases. Also, we have hematological changes like decreased hemoglobin and hematocrit count due to hemodilution and increased leukocyte count also. In the GIT system, we have increased reflex and decreased motility, and increased oxygen consumption is also there when we talk about the respiratory system. So here we'll be mainly focusing on the periodontal diseases which occur during pregnancy. Now here will just like to share that most of the periodontal changes which occur during pregnancy are due to the hormonal changes which we have in a pregnant female. When we talk about hormonal changes, we'll be mainly focusing on estrogen and progesterone hormones. So progesterone, it reaches a level of 100 nanogram per ml, that is 10 times the peak luteal phase of menses. And in early pregnancy and during the normal ovarian cycle, the corpus luteum is the major source of estrogen and progesterone. Now, during pregnancy, what happens? Even the placenta, it begins to produce estrogen and progesterone. So, because of this, the progesterone level reaches to as max as 100 nanogram per ml. Now, this level rises until the 8th month of pregnancy, and after that, it becomes stable until birth. The estrogen level also rises slowly until the end of the pregnancy. Now, it is because of these elevated level of hormones in blood and saliva which causes various gingival and periodontal changes. Now, what do normally estrogen and progesterone do? Estrogen, it mainly regulates the cellular proliferation, differentiation, and keratinization, whereas progesterone, it influences the permeability of the microvasculature. It alters the rate and pattern of collagen production and increases the metabolic breakdown of folate, which is necessary for tissue maintenance. Progesterone, it also plays a role in stimulating the production of prostaglandins that mediate the body's response to inflammation. Now we all know that prostaglandins are the main molecules that mediate the body's response, and progesterone, it directly stimulates the production of prostaglandins, hence thereby causing the gingival and the periodontal changes. Uh, Briefly talking about the microbial changes and its impact on periodontal disease during pregnancy, definitely there is an alteration in the composition of subgingival plaque during a pregnancy. The bacterial anaerobic to aerobic ratio is increased, including bacteroides melanogenicus and Prevotella intermedia. And there have been various studies that have suggested that estradiol or progesterone can substitute for menadiol, that is vitamin K, which is an essential growth factor for Prevotella intermedia. See, we all know that Prevotella intermedia is a very important microbe which causes periodontal disease. And what happens in pregnancy, as the progesterone level increases, it substitutes for vitamin K or menadiol, which is a growth factor for Prevotella intermedia. Hence, the count of Prevotella intermedia, it increases many a times, and this increase in the Prevotella intermedia directly leads to periodontitis. Also, it has been found that there is increased concentration of Porphyromonas gingivalis during the 21st through 27 weeks of gestation. Now, this relative increase in the number of Prevotella intermedia is considered a more sensitive indicator of an altered systemic hormonal situation than the clinical parameters of gingivitis. So, what we are saying here is that the increase in Prevotella intermedia is definitely a more sensitive indicator of an altered systemic hormonal situation than the markers of gingivitis. Then talking about the immunological changes and its impact on periodontal disease during pregnancy, the maternal immune system, it is thought to be suppressed during pregnancy. This is mainly to allow the fetus to survive as an allograft. There is a marked increase of monocytes and pregnancy-specific beta-1 glycoproteins that contribute to diminished lymphocyte responsiveness to mitogens. At the same time, the ratio of peripheral T helper cells to T suppressor cells has been reported to decrease throughout the pregnancy. So, these changes in maternal immunoresponsiveness suggest an increased susceptibility to develop gingival inflammation in a pregnant female. Then, the changes in gingiva which occur during pregnancy we will be talking in detail. First of all, gestational gingivitis. Gin- As we all know, gingivitis is inflammation, and this inflammation is initiated by the oral biofilm. That is, the plaque and calculus is present supragingivally as well as subgingivally, which leads to gingivitis, and it is exacerbated by increase in the endogenous sex hormone levels. It has been found that pregnancy-associated gingivitis is a bacterial infection-induced inflammatory disease and affecting the gingiva with a high prevalence of 35% to as much as 100%. So you can see the extent to which gingivitis is prevalent in pregnant female. And these are the classical signs and symptoms in the oral cavity which we find in a pregnant female. There will be red swollen gums. You will find lot of plaque and calculus in such kind of patients who have swollen gums. These gums will bleed easily. At the same time, patient will complain of bad breath. These gums will be very tender and sometimes very painful. There will be sensitivity to heat and cold. At the same time, in such patients, if we check the probing depth, there will be a marked increase in the probing depth. So what happens in a pregnant female? There are already a lot of inflammatory changes. The plaque and calculus lead to an inflammatory state, and the immune response of the body is also leading to an inflammatory state. Depending on the women's metabolism, the lifestyle habits, and the nutritional patterns, there's an inflammatory response which leads to dysbiosis of the oral microbe and production of matrix metalloproteinases, cytokines, prostaglandin E2s, and these prostaglandin E2s directly affect the periodontium and lead to inflammation and the effect on the periodontium will extend from healthy gums to gingivitis to mild periodontitis to cases of severe periodontitis. So the altered host physiology tends to accentuate the normal inflammatory reaction to plaque accumulation, leading to rapid deterioration of the oral condition. So what we are saying here is definitely plaque and calculus is present in the oral cavity, and the host physiology is also altered, which tends to accentuate the normal inflammatory response of the plaque and calculus, and this leads to rapid deterioration of the oral condition. However, the degree of severity of pregnancy-related gingivitis appears to be largely determined by the individual's oral hygiene rather than the effect of the altered immune response. So, if a patient is having good oral hygiene, the patient has got prophylaxis done before planning for pregnancy, definitely the hormonal imbalance which will be affecting the periodontium, will be of a much lesser extent as compared to an individual who is not taking care of the oral hygiene. There has been a study in 2018 by Keshetiri et al. On 120 pregnant and non-pregnant female to assess the oral hygiene status, gingival status, periodontal status, and the treatment needs. It was found that gingivitis was prevalent in almost all the pregnant and non-pregnant women. However, those female who had taken good care of their oral hygiene status and gingival status before planning for pregnancy, definitely in those patients, the extent of gingivitis was found to be much lesser. Now, many a times this gingivitis may resolve on its own after delivery, postpartum, or if it persists, we may go for non-surgical treatment, and in case of severe cases, surgical treatment may be required. Then a very classical finding in cases of pregnant female is pregnancy tumors. It is, as you can see, this is a very classical finding, and if many a times a pregnant female may come to you with this kind of growth in the gingiva. It is found in 5% of pregnant women. It is associated with edema with gingival overgrowth, and an increased tendency for bleeding. Now, this growth may be extensive and can interfere with performance of functions like mastication, speech, and chewing. And many a times, the patient may be having pain in such cases, and it will interfere with the normal daily functions of the patient. Now, what happens exactly that during the first month of pregnancy, there is persistent influence of plaque, and this plaque leads to base of development of hyperplastic gingiva. Because of the plaque and calculus, there is formation of hyperplastic gingiva, and this is modulated by the accumulating hormonal stimuli, which leads to occurrence of pyogenic granuloma. The increased level of estrogen, it enhances the vascular endothelial growth factor production in macrophages, which may be related to development of pregnancy tumor. At the same time, the increased progesterone, it functions as immunosuppressant in the gingival tissue, preventing a rapid acute inflammatory reaction against plaque, but allowing an increased chronic tissue reaction, resulting clinically in exaggerated appearance of the tumor, of the gingival overgrowth. However, the molecular mechanism for regression of pregnancy tumor after parturition still remains unclear, and it has been proposed that the absence of vascular endothelial growth factor angiopoietin 2, it causes the blood vessels to regress, and the protein level of angiotensin 2 was highest in the pregnancy tumor, followed by those after parturition and normal gingiva. The amount of vascular endothelial growth factor was high in granulomas in pregnancy and almost undetectable after parturition. So, it was the increased level of vascular endothelial growth factor and angiopoietin 2, which was found to increase during pregnancy and after pregnancy. In the absence of vascular endothelial growth factor and angiopoietin 2, it caused the blood vessel to regress, and hence the pyogenic granuloma many a times it may regress after pregnancy. The treatment, it depends on size of lesion and on severity of symptoms. If the tumor is small and does not bleed, clinical observation is recommended, and the treatment definitely includes improvement of oral hygiene to remove the irritating factors. In case of bleeding and pain following toothbrushing or chewing, conservative surgical treatment is advisable. Then we'll be discussing the few of the main adverse pregnancy outcomes. Periodontal pathogen and their metabolites can lead to adverse pregnancy outcomes through direct or indirect pathway. Direct pathway through the systemic circulation and indirect pathway via liver. These adverse pregnancy outcomes include preeclampsia, low birth weight, and preterm birth. We'll be talking each of them in detail. Just briefly discussing the pathogenesis of adverse pregnancy outcomes. As we have already said, periodontal disease mainly leads because of the periodontal bacteria and their byproducts. These byproducts, they enter into systemic dissemination, and via the systemic circulation, they directly affect the fetus. Indirect pathway, these inflammatory mediators, they act on the maternal liver, lead to production of acute phase reactants. They lead to systemic inflammation and affect the developing fetus. Because of all these inflammatory mediators and their effect on the fetus, there is infection of choriodecidual and chorioamniotic membrane, placenta, and fluids. At the same time, there is placental inflammation, production of growth factors. All these collectively lead to adverse pregnancy outcomes. First of all, talking about preeclampsia, it is a maternal multi-organ disease that clinically manifests in the second half of the pregnancy with the appearance of hypertension and proteinuria. It is a disorder unique to pregnancy with a prevalence of approximately 2 to 3%, and it is one of the leading causes of maternal morbidity and mortality in the world. Because periodontal disease is also associated with low-grade inflammation, it can be hypothesized that patients with periodontal disease may have an increased risk of developing preeclampsia. So, as we know, in periodontitis, there is increased periodontal inflammation. At the same time, there is release of bacterial byproducts, the pathogen-associated molecular patterns. They enter into the systemic circulation and lead to a pro-inflammatory placental environment, which mainly includes neutrophil and macrophage dysfunction, production of inflammasomes, activation of toll-like receptor 2 and 4, oxidative stress, and endothelial dysfunction. All these collectively lead to preeclampsia. Now, there has been a systemic review and meta-analysis in the year 2022, in which 30 studies, including 6 cohort and 24 case control studies, were selected. And in this systemic review and meta-analysis, there was a significant association of periodontitis and preeclampsia. It was found that patients with periodontitis were at increased risk for preeclampsia. The treatment includes bed rest to lower blood pressure and increase blood flow to the placenta, and close monitoring of the woman and her fetus will be needed. There are few investigations for the mother, which include blood and urine tests to see if preeclampsia is progressing, platelet count, liver enzymes, kidney function, and urinary protein levels are assessed. And in fetus, ultrasound, heart rate monitoring, and amniotic fluid assessment is done. Then coming to the second adverse pregnancy outcome, first one which we had talked about was preeclampsia, in which basically there was hypertension and increased proteinuria. The second one will be low birth weight. Now, what we had talked earlier in the beginning of the presentation, the average birth weight which we take is 3.5 kg, and babies having birth weight less than 2500 gram are represented as low birth weight babies. They have disproportionately large amount of neonatal and infant mortality rates. Although low birth weight babies make up only about 6 to 7% of all the births, but they account for more than 70% of neonatal deaths. Now, what happens that there is already presence of bacterial byproducts because of periodontitis, which leads to production of pro-inflammatory cytokines. They directly enter into systemic circulation, or via liver. There is production of acute phase reactants from the maternal liver. All these membrane lead to placental inflammation, reduction of growth factors. These inflammatory mediators may also lead to bacterial invasion of the membrane and the placenta. At the same time, there is production of there is activation of toll-like receptors and increased prostaglandin E2 production. Because of the growth factors, uh, production is reduced. There is damaged architecture, which leads to preeclampsia and low birth weight. At the same time, the fetus development is also affected, which may lead to miscarriage, perinatal mortality, and long term disabilities. Because of the activation of TLRs and the increased production of prostaglandin E2, it may lead to membrane rupture and uterine contraction, and all these factors together lead to preterm birth. A study was carried by Gardner et al. In the year 2013, in which a relationship was established between maternal periodontal disease and low birth weight babies. And in this study, it was concluded that maternal periodontal disease could be an independent risk factor for low birth weight babies. So here, when they assess the periodontal status of women during perium and determine the relationship between periodontal disease and low birth weight, they found that it was an periodontal disease was an independent risk factor. Then coming to preterm birth, premature delivery is among the leading causes of perinatal mortality and morbidity in developed societies, which is an important obstetric problem. Maternal periodontitis is a prevalent condition that has been suspected to be associated with adverse pregnancy outcomes such as premature birth. Again, the direct and the indirect direct pathway via the systemic circulation, and indirect pathway via the maternal liver, which leads to production of C-reactive proteins. All these create a state of inflammation, which induces preterm birth. There, a study was done in the year 2021 assessing the association between periodontitis and premature birth, and they had found that a statistically significant association is there between periodontitis and premature birth, and women who had periodontitis had 6 times the odds of giving birth to premature birth infants compared to women who had no periodontitis. Now, when to refer a pregnant female to a periodontitis? In case of gums that bleed spontaneously while brushing, in cases of red, swollen, or tender gums, when the patient is having severe pain on chewing food, problem of persistent bad breath, there is formation of pus between the teeth and gums, and loose or separating teeth. So, how should we avoid periodontal disease during pregnancy? A simple maintenance of oral hygiene has to be recommended to the patient. If the patient is having a good oral hygiene, a patient has got the prophylaxis done before planning pregnancy, or and the patient's oral hygiene is well taken care of, then in spite of the hormonal imbalance, the chances of periodontitis are reduced many a times, thereby reducing the occurrence of adverse pregnancy outcomes. So we should always motivate the patient to have a good oral hygiene, take care of the periodontium throughout the pregnancy, and especially in educated patients, we need to give them the information that there is a strong association between periodontal disease and pregnancy. Patients should get personalized advice on oral health, and it is advisable to get oral prophylaxis done before planning pregnancy. If required during pregnancy, any elective procedure to be preferably be done during second trimester. So all elective treatment as recommended in the guidelines is should be done in the second trimester. The treatment recommended during pregnancy, the physical control of the biofilm involving removal of supragingival and subgingival plaque and calculus. The chemical control mainly includes prevention of periodontal disease, including daily use of antiseptic with cetyl pyridinium chloride, and in cases of severe periodontal disease, antiseptics that combine chlorhexidine and cetyl pyridinium chloride should be given. There is a briefly discussing the dental treatment protocol to be followed during pregnancy. In first trimester, we should educate the patient about the maternal oral changes that occur during pregnancy and emphasize strict oral hygiene instructions and thereby plaque control throughout pregnancy. Limit the dental treatment to periodontal prophylaxis and emergency treatment only, and avoid use of routine radiographs. Use selectively and when needed in cases of emergency treatment only. In the second trimester, oral hygiene instructions should be reinforced and plaque control should be done. Scaling, polishing, and curettage may be performed if necessary. Control of active oral diseases should be done. Elective dental care, if of utmost need, is safe to do. We should avoid use of routine radiographs and use selectively and when needed. So any non-surgical treatment, if has to be done, preferably it should be done during second trimester. And elective dental care should be only carried out if it is of emergency need. Otherwise, we can always delay any elective treatment postpartum. In the third trimester, we should give always short dental appointments with appropriate chair positioning to prevent supine hypotension. It is safe to perform routine dental treatment in the early part of the third trimester, but from the middle of the third trimester, routine dental treatment should definitely be avoided. I would also like to discuss briefly the chair positioning of a pregnant female when we are carrying out the dental treatment. Keep the patient's head at a higher level than the feet. Place the patient in a semi-reclined position as tolerated and allow frequent position changes. It is always advisable to place a small pillow under the right hip or have the patient slightly turned to the left. In a semi-reclining or supine position, the great vessels, particularly the inferior vena cava, are compressed by the gravid uterus. By interfering with the venous return, this compression will cause maternal hypotension, decrease cardiac output, and eventual loss of consciousness. So we should always avoid supine position. And when the patient is sitting on the dental chair, always advisable to make the patient turn slightly to the left. We can keep a pillow on the right side and ask the patient to slightly turn. Briefly talking about the medications which are considered safe during pregnancy, the local anesthetics lidocaine, prilocaine, etidocaine, and articaine are considered safe to use. If you talk about analgesics, acetaminophen, hydrocone, and oxycodone are safe to use. Penicillins and erythromycins in antibiotics can be given along with clindamycin. Cephalosporins can also be given. Tetracycline should definitely be avoided. Ciprofloxacin should also be avoided. And metronidazole should be avoided, and their use is still controversial. Drugs which should not be used include benzodiazepines, barbiturates, and nitrous oxide. So, to conclude my presentation, during pregnancy, the probability of developing periodontal diseases increases. Mothers who have periodontal diseases are more likely to have a preterm delivery or low birth weight baby. Regular dental checkup should be done before and during pregnancy and a basic for controlling oral health. And definitely, if the patient is having good oral hygiene throughout pregnancy, the chances of developing periodontal disease are reduced many a times. Thank you so much. I would also like to thank the PG student, the PG students for coordinating the presentation, and Dr. Saundarya for being there in arranging this lecture. Thank you so much. Thank you, sir.
Thanks a lot, Aena, for such an insightful and detailed presentation. Like you opened up our eyes with regard to this particular topic. The way in detail you explained that how pregnancy, periodontitis in pregnancy can cause preterm low birth weight babies, as well as the development of pregnancy-induced hypertension, preeclampsia. With all this knowledge, I am sure that it is not just the PGs of Department of Periodontology and Implantology which would have gained a lot, but it is also PGs of other specialities as well as faculty, as well as dental practitioners would have gained a lot through your clinical tips. Those tips of changing frequent chair positions with regard to
Yes,
pregnant patients, which drugs to give and which not to give. Heartiest congratulations, Dr. Aena, and thanks a lot again for accepting our invitation. I can see that few queries are there from few of the
yes, sir.
postgraduates in the comment section. So I request Dr. Roopsi to please conduct the question and answer session.
Yes, sir. Thank you so much, sir.
Ma'am, the first question is from Dr. Nakshi Yadav that should we avoid flap surgeries in the second trimester or not?
Yeah. See, what has been advised in literature is that any dental treatment which is of utmost urgency should be done in second trimester. That includes mainly the non-surgical treatment, oral prophylaxis, and use and curettage. I feel flap surgery is definitely and not an elective treatment, because we all know periodontal disease is a slow progressive disease, and patient will not give you any such signs and symptoms in which patient needs immediate treatment. In cases of when do we go for a periodontal flap, patient will be having deep pockets, there will be mobility, bone loss. So that all those clinical things are not such that you have to do it immediately in the second trimester. What we can do, if a patient is there who is having red swollen gums, mobility is there, pus discharge is there, you can definitely go for an oral prophylaxis, do curettage, and you can educate the patient that if once the baby is delivered, the patient can always come back to you and the flap surgery be done. So, as per me, I always avoid flap surgery in the second trimester.
Thank you, ma'am. The next question is from Dr. Soumya Sharma that are there any considerations we need to keep in mind for patients on oral contraceptives or hormonal substitutes regarding periodontitis?
Definitely yes. See what happens in patients on oral contraceptives, there will be an increased level of progesterone and estrogen, and it has always been mentioned in literature. Even Linde had given a study, I think in 1967, in which a 1 year study was done in patients who were on oral contraceptives, and it was found that there is increased gingival exudate in the anterior area. Also, we will find in patients who are on oral contraceptives, there will be an increased probing depth, there will be gingival swellings, and many a times loss of attachment will be there because the hormonal imbalance is there. So the periodontium will be definitely affected, and that will be visible to you.
Okay, thank you, ma'am. Now I would like to request our dynamic principal and dean, Dr. Nikhil Srivastav sir, to kindly felicitate our guest speaker, Dr. Reena Jain Pundir ma'am, and also to kindly say a few words.
Thank
Good
you,
morning,
Aena.
sir. So
Good
thank you
morning.
so much, sir. Good
Thank you
morning, sir.
for your informative lecture. Actually, Aena, we are still celebrating the World Oral Health Day,
Yes,
and
sir.
this time, this thing. The theme is that a happy mouth is a healthy body.
Yes,
So
sir.
this actually denotes the link between the whole body and the oral cavity. So
Yes,
you
sir.
picked up a very good topic, and here in Women Empowerment Committee of the university, we have been educating our particularly the non-teaching faculty regarding all these things, that what can be the association of the oral cavity and rest of the
Yes,
body,
sir.
and how can they
Yes, sir.
take care of the whole body and oral cavity. So thank you very much.
So,
As already said, no, that this particular initiative, what we call it as SALS, which is the Subharti Alumni Lecture Series, our very aim is to connect our old alumnus and old students to the current generation who are currently studying, so that they not only get a little bit of increased knowledge, but also they should be inspired that yes, our own students after passing out, they are doing exceedingly well in private practice and in academics all across country. So, congratulations to you. I just read your CV that you are currently working as professor and head in Chhattisgarh, and you also
yes,
run your practice. So, all the very
yes.
best for future endeavors, and keep the Suvarti flag high.
Thank you so much, sir. It is an honor to listen such words of praise from you. You have been yourself such an inspiring person when we were studying as a student in Subharti, and I'm really grateful to you for giving me this opportunity today, and to Mayur Kaushik, sir, and to all the students who are listening. You are having a privilege, and it is a great honor for you to do post graduation in Subharti. So please work hard, and you have wonderful teachers over there to guide you. And sir, learning over there is a privilege in itself. And whatever we had learned from Subharti, it is all because of that whatever little we are able to achieve till date.
All
Thank you
right.
so much, sir.
Thank you, Aina. Thank you for your time. And on behalf of complete Subharti family, kindly accept a token of appreciation, a certificate from our side.
Thank you so
Kindly
much.
accept it. And
Yes, sir.
do visit Subharti whenever you get a chance. Every year we are holding our alumni meet also, and we try to invite all our alumni, particularly those who are distinguished in their own field. So
Yes,
do
sir.
come and stay
Surely,
connected
sir.
and college.
Surely, sir.
All the very
Surely,
best.
sir.
Thank
Thank you so much, sir.
you.
Thank you so much, sir, for such wonderful words. I would like to thank Dr. Reena Jain Pundir ma'am for taking out time from a busy schedule and be with us today. Also, my deep regards to Dr. Ratul Krishna sir and late Dr. Mukti Bhatnagar ma'am, founder of Subhati Group of Institutions, for the constant support and guidance they have provided us. Also, I would like to extend my thanks to our young and dynamic CEO, Dr. Shailya Raj ma'am, and our Vice Chancellor, Major General Dr. G.K. Thapliyal sir, for motivating us. Thank you, ma'am and sir, for being a pillar of support to all of us. I would like to express my heartfelt gratitude to our Principal and Dean, Dr. Nikhil Srivastav sir, for always guiding us and motivating us to excel in our field. I would also like to thank our professor and head, Dr. Mayur Kaushik sir, under whose positive and motivational guidance such events could take place. Last but not the least, I would like to thank all the faculty members and our dear postgraduate students for always supporting us. Thanks to Mr. Jatin and Mr. Shubham from the IT team who has made these lectures possible. Thank you.